my task is to give a bit of an overview of how we can use behaviour change theory to understand and overcome barriers to physical activity and exercise. Let me just advance that slide. So what I'm going to cover in the next 10 to 15 minutes is to talk to you about the behaviour change frameworks that we like to use at our centre to inform our exercise and physical activity interventions, but to also work with our patients and clinicians in trials to help overcome some of those challenges with participation and adherence that Kelli talked to. I'm going to give a bit of an overview of the theoretical domains framework, which is the TDF, which can be used to understand the determinants of behaviour. And I'm going to particularly focus on what we know from the literature about the common barriers to physical activity and exercise in people with OA. I then want to touch on the Combi as a model that we can think about for how we might want to intervene with our with patients and people with OA to increase their physical activity and encourage these positive exercise behaviours. And then I'll just finish my talk with a few examples of the different strategies that we sort of weave into our interventions at our research centre. So Jackie's already introduced, I think, quite nicely at the very beginning, the real complexities around behaviour change with physical activity, and in fact, how many different things a person needs to do just to follow what seems to be a very simple instruction or piece of advice to exercise regularly. People need to seek out healthcare, they need to act on referrals to exercise providers, they may need to purchase exercise equipment, or perhaps go off and attend a group class or exercise facility. Obviously then undertaking the exercises regularly and at the appropriate dosage, usually over a prolonged period of time for conditions such as osteoarthritis. Probably over time being able to monitor their program and know how to adapt it and what to do in case of a pain flare, because that is common and is to be expected with exercise, and often attending follow-up appointments as well with their exercise provider. So it really is no surprise when we see those declining adherence rates that Kelli spoke about, that in many cases people just can't be bothered, they just don't know what to do. So we use the theoretical domains framework to understand the types of barriers that people with osteoarthritis encounter. And I'm not going to go too much into the framework itself. I'd rather talk more about the actual barriers. But for those who aren't familiar with the TDF, it's a synthesis, or it draws together 33 different theories of behaviour change and brings together 128 different theoretical constructs into the one theory, if you like, and it clusters these into 14 domains. And I'll show you those on the next slide. But the nice thing about the TDF is it gives us a theoretical lens through which we can look at all of the different influences on behaviour. And these influences can be cognitive, affective, social, or environmental, and you'll see that environmental plays quite a role in osteoarthritis. And importantly, the TDF can help us understand the factors influencing not only patient behaviour, but as Kelli's already alluded to, the really important role that clinicians and healthcare providers play, but also clinician behaviour. And I will touch on that a little bit at the end of my talk as well. So these are the 14 domains in the theoretical domains framework. I won't go through all of them, but I'll just point out, a couple of examples here. So for example, if we look at the domain of knowledge, does the patient have the knowledge to perform the exercise or participate in the physical activity as instructed? Do they have the skills, i.e. sufficient training to actually perform the exercises that they've been prescribed? What about their beliefs about capabilities? Do they actually believe that they're capable, and are they confident in their ability to actually perform the exercise program, particularly if they've been advised to do unsupervised exercise or exercise on their own outside of that sort of familiar, healthcare environment that often provides a lot of support for a patient to exercise safely. So you can see the 14 different 14 domains in the TDF. And what we did was conducted a scoping review of qualitative and quantitative studies that explored barriers and facilitators to exercise and physical activity in people with OA. And what we found is that there's an absolute multitude of barriers and facilitators to exercise, and that they fall across all 14 of those domains in the TDF. But what I've drawn out here is the main, or some of the big ones here on this slide. And a lot of barriers cluster around an individual's knowledge. So what really becomes apparent from the literature is that patients who have a lack of knowledge or understanding about osteoarthritis and the condition that they're suffering really found that is a barrier to participating in exercise. And linked to that is inadequate instruction or knowledge about how to exercise and when and how much. And importantly, also about a lack of knowledge about the benefits of exercise. There's a lot of false beliefs out there amongst patients, and many people actually think exercise is harmful as opposed to those benefits that Kelli's already gone through in the first talk. Another really important aspect is an individual's belief about their individual capability to exercise. And this is quite a big one, in that lots of people with osteoarthritis actually believe that people with OA themselves shouldn't exercise because they're not capable. This can be reflected in a physical capability, and often comes through particularly in people who are suffering from excess weight or comorbidities. And we know that comorbidities are really common with OA, but also related to the belief that having symptoms, having knee pain just means that you can't exercise. And having a really negative attitude at the outset there, and that can be a real barrier. Another big one is beliefs about consequences, and patients who really hold false or misconceptions in the sense that exercise will actually be harmful for their joint. So there's a lot of people who think it's going to make pain worse, symptoms worse, or in fact actually damage the joint. And indeed, some people think exercise might be what caused their osteoarthritis in the first instance. And then there are others who just simply don't believe or don't understand that exercise actually can be effective for people with the condition of OA. So that's a really big barrier as well. You can see a big long list here under environmental context and resources, and this is a really important domain, I think, that is important for all clinicians to consider. There's no end of barriers here, where some accessing facilities, the weather, if people have been asked or instructed to be physically active outdoors, costs and financial barriers can be a real problem with attending exercise classes. And it might even be something as simple as purchasing new shoes or clothing that's appropriate for exercise or exercise equipment. People who live in environments that are particularly hilly or lots of stairs, that too, it seems really simple, but these can be really sometimes what seems to be insurmountable barriers to people with OA. And obviously transport and parking for those people who are needing to attend exercise facilities as well. And then the other that I'll point out at the end here as well is around intentions or lack of motivation to exercise. This comes through as a really strong theme with patients really talking about lack of motivation as a barrier, a sense of laziness, and it's often compounded by the belief that the person believes they're already sufficiently active. And I think Kelli's presented some really nice data to show us at the beginning that in fact the vast majority of people with OA aren't sufficiently active. And what I've tried to articulate here in the slide is that lots of these things really feed into each other, and create this vicious cycle that can really make it quite challenging for a patient to break out of and actually engage in an exercise behaviour, even if they've been encouraged to. So someone who has no knowledge about exercise benefits may then have these false beliefs or hear about misconceptions from someone else that exercise is actually going to be harmful. And then that feeds the belief that, well, they're not actually capable of doing exercise, and that a person with OA shouldn't do exercise, all compounded by any comorbidities that the person may have. This all feeds into a lack of motivation to actually seek care from a healthcare provider for exercise. And alarmingly, increasing research is showing that these sorts of attitudes about exercise may actually drive patients to seek out surgery, or may make them more willing to engage in surgical interventions without even trying non-surgical interventions in the beginning. So the Combi system is a nice system for thinking about how we might want to change a behaviour. And I've put over here as an example, let's say the behaviour that we want the person to do is to perform exercise, and they're given exercise program 3 times a week. Well, for that behaviour to happen, there are three important factors over here on the left need to be in play. And that is that the patient is capable of performing that exercise program, that the patient is motivated to do it, and that the person has opportunity. And opportunity refers to those external things in their environment that make something able to happen. And if we think about behaviour in this way, it can help us start to think about different strategies that we might use to help intervene. And I realise this is a busy slide, but I've just drawn on some of the barriers that I've just talked about with the TDF to put in some ways that we may overcome these. So if we're thinking about barriers around capability, and noting that capability can be physical in the sense that the patient actually doesn't know how to exercise. Well, obviously training and teaching patients how to perform exercises safely and correctly is important. But so too may be using a tailored exercise approach with a graded, starting small, starting gently, and building that up to show the patient and let them realise that they are physically capable of exercising. And obviously strategies such as verbal, written resources, exercise videos, apps, all of these things help to remind people for once they've forgotten, or to refresh and remind them how to perform and undertake these activities. But capability is also psychological. Patients need to have realistic expectations about timeframes. And I think these are really where the role of the clinician is really important. And I really, we really believe really strongly in how important education and information is to patients when prescribing exercise. And that includes information about the likely prognosis and the benefits of exercise, the expected timeframes so that people have realistic expectations, giving people specific exercise instructions, a whole raft of factors there. If we look at motivation, we can see that by giving people positive beliefs about the effects of exercise, that will motivate them to actually participate. And that includes giving them positive beliefs about their capacity for exercise. So telling people and using role models or testimonials from other patients with OA can really help to show patients that they do have the capacity. If this person, this older person, can exercise, well, so too can I. Finding other levers for motivation, such as becoming more physically active to prevent functional decline in the future, can work with some patients, but really creating a sense of optimism about OA, exercise, and their future prognosis. And again, I think this is a really key part for where clinicians need to play a role in reinforcing and providing those links to the patient between exercising and helping them monitor their symptoms and reflect on improvements that they may have missed over time, but once the clinician works through with them, then they can highlight those small improvements and goals that have been achieved, and that becomes motivating in and of itself. And obviously opportunity is really important. We talked about the external barriers, helping advise patients where and how to purchase equipment. In fact, don't recommend exercises if the patient can't afford to purchase exercise equipment. Use prescribed programs that use body weight or home programs. So really advocating a shared decision-making approach for the type of exercise. Whoops, sorry about that. that is used in a program. Unfortunately, if we look at the, it's really patchy how many clinicians are using behaviour change techniques with their patients with NEOA. This is some data from a survey we conducted with patients a few years ago, asking them about what sorts of behaviour change techniques they'd experienced when they'd been given, been prescribed exercise. And you can see, pleasingly, the top one there is an explanation of the potential benefits of exercise. However, alarmingly, that was only reported by 50% of people in the survey, and that was the top one. And then it just goes downhill from there. Only 40% of people had actually been given educational materials about the benefit of exercise. Only a third given written instructions about what to do, or a plan telling them specifically how often and when to exercise. So there's a lot of room for improvement there. The types of strategies we bring into our interventions. So we have, these are just an example from one of our recent trials. We have, a comprehensive range of educational booklets that we provide to our patients that has written information about OA and exercise, with really comprehensive written instructions, diagrams and photos about exercise, logbooks for people to record the exact program that they've been prescribed, and to record and monitor when they've done them, and indeed any challenges that they might want to take note of to talk about with their clinician next time. Where possible, and depending on the trial, we provide simple exercise equipment such as elastic bands. And we've created optimistic videos explaining what osteoarthritis pain is and the benefits of exercise in an effort to help with that. We've also done some work developing a website with all of these elements of education and activity on them that's been evaluated, and that's available for people to use. And we've also looked at using creating behaviour change messages to help support and overcome barriers to exercise that we've done and delivered by SMS, and more recently have developed into a mobile application. Kelli's already alluded to the important role that clinicians play, and clinicians indeed have many misconceptions like patients do. And so it's really important that we also address concerns that clinicians have and knowledge that clinicians have, because if they don't have accurate knowledge, our patients can't have accurate knowledge. And so we also now probably take quite a two-pronged approach in our research trials, where we're upskilling clinicians as well. And this is an example of an educational course for physiotherapists that we have developed in an effort to do that. And I'm going to finish up there with a shout out to my team here in Melbourne, who without them, all of our work wouldn't be possible.